Bismillah ar-Rahman ar-Rahim. Pulmonary arteriovenous malformations. The etiology. The pulmonary arteriovenous malformations are abnormal blood vessels replacing normal capillaries, making a direct low resistance connection between the pulmonary arterial and systemic venous circulation. They vary in size from tiny clusters of vessels, telangiectasias, to larger, more complex aneurysmal type sacs. The disorder is rare, affecting 1 in 15,000 to 24,000. Several genetic susceptibility loci have been identified on chromosome 9 and chromosome 12. One identified mutation is in the endogen gene. This modulates signaling via the TGF beta family of growth factors. This gene is also implicated in the development of primary pulmonary hypertension. Subjects with significant pulmonary arteriovenous malformations have low pulmonary vascular resistance, a low mean pulmonary arterial pressure, and a high cardiac output due to long-standing adaptive mechanisms to the effects of the shunt, in addition to vascular remodeling effects. Most patients present post-puberty as arteriovenous malformations probably develop at this time. They probably grow throughout the life, especially during puberty and in pregnancy. They may rarely regress spontaneously. Larger or more numerous arteriovenous malformations are associated with greater complications and are more likely to present earlier. The diagnosis. Most patients present with abnormal chest X-ray, classically showing smooth, rounded intrapulmonary mass with draining or feeding vessels. Mild hypoxemia. An AVM is a direct communication between the pulmonary artery and the pulmonary vein. Blood therefore bypasses the pulmonary capillary bed with reduced oxygenation, which poorly corrects with supplementary oxygen. Orthodoxia is saturation on standing due to an increase in blood flow in the dependent lung areas. 70% of pulmonary arteriovenous malformations are basal, hence the desaturation seen. CT identifies all AVMs and can determine those suitable for embolizations. Contrast is not required, though a computed tomographic pulmonary angiogram is required pre-embolizations to better delineate the vascular anatomy. Patients may present with the complication of a pulmonary arteriovenous malformation, particularly bleeding or peripheral abscess formation. The absence of a normal filtering capillary bed means small particles can reach the systemic circulation, leading to sequelae, particularly in the cerebral circulation, strokes, and cerebral abscess. These abnormal vessels are also at risk of rupture. The shunt quantification 100% auto-rebreathing study, a non-invasive method of shunt quantification. 99 TC perfusion scan, a tracer study. The size of shunt can be assessed from proportion of radiolabeled macro aggregates reaching the systemic circulation compared with the total number injected. Normal study aggregates accumulate in the kidneys. Contrast echo Contrast echo to measure the circulatory transit time of injected echo contrast. Angio- Angiography at specialist center only. In normal individual, the anatomical shunt is below 2 to 3.5% of the cardiac output due to post-pulmonary drainage of bronchial veins into the pulmonary vein and drainage into the left atrium. The clinical features of pulmonary arteriovenous malformations include the following. The case may be asymptomatic in 50%. There are dyspnea, hemoptysis 10%, probably due to additional bronchial telangiectasia, which can also cause hemorrhage into bronchi or the pleural cavity. Chest pain in 12%. The etiology is uncertain. Clubbing, cyanosis or pseudoxia, vascular bruise, telangiectasias. 80% of pulmonary arteriovenous malformation patients have hemorrhagic or have hereditary hemorrhagic telangiectasia, and their families should be screened because of the risk of the stroke. The patient may present with acute stroke with focal neurological signs. The management of pulmonary arteriovenous malformations include the following. Embolization is usually done with coils which generate local thrombin leading to cessation of blood flow. Prophylactic antibiotics for dental and surgical procedures. Surgical resection may be more appropriate than embolization in some cases. Antiplatelet therapy rarely used in individual cases if ongoing transient ischemic attacks. Transplantation is not advised as there is no increased survival benefit over medical treatment. Screening. The majority of patients with pulmonary arteriovenous malformations have hereditary hemorrhagic telangiectasia, and so screening of family members is important. Follow up. All patients need regular follow up with shunt assessment. Post surgical resection or embolization, as removal of one shunt may unmask or provoke the development of others. Female patients should be advised to defer pregnancy until completion of formal assessment because of the risks of growth and rupture of pulmonary arteriovenous malformations in pregnancy. Complications. Pulmonary arteriovenous malformations patients never die of respiratory failure in the absence of additional respiratory disease. All patients are at risk of stroke and cerebral abscess. Transient ischemic attacks or strokes in 25% due to rupture of abnormal capillaries in aneurysms. Abscess in 10% due to paradoxical emboli through the right to left shunt and the absence of a filtering capillary bed. The pregnancy associated with an increase in size of arteriovenous malformations, and the new ones may develop with potentially catastrophic consequences. The careful shunt assessment is therefore to prior needed prior to pregnancy, with contraceptive advice prior to specialist assessment. Close contact between the specialist center and obstetrician team is paramount. Arteriovenous malformations may need embolization in the third trimester to allow safe delivery.